globalizing the gold standard, mission thrombectomy, and universal access. These are my disclosures. I do consult for companies that make thrombectomy devices, and I have some stock options in a company, Rapid Medical, and also Gravity, but I don't have any royalties, and I'm the Global Chair Emeritus and founder of Mission Thrombectomy. So this is where I come from, Miami, Florida, and work at Jackson Memorial Hospital, which is a large public hospital in the Miami County. That's about 1,000 beds. It's one of the largest hospitals in the US. I know your hospitals, including Ho Chi Minh City, are even a lot bigger, but this is definitely a premier stroke center, what we call the Comprehensive Stroke Center. And across the street, we have the University Hospital, which is private and owned by the University of Miami. And we also, it's a primary stroke center, and we cover, my team and I cover both hospitals for thrombectomy and neurointervention. So the problem of acute stroke and stroke in general is something that we should think about, in my view, as a long neglected pandemic. Even though, strictly speaking, a pandemic is an infectious disease, and we know stroke is a non-infectious, non-communicable disease. But think about it. Globally, there is about 13.7 million strokes a year, 9.5 of which are ischemic, and they lead to 5.2 million deaths a year globally. And that is probably, beneath the issue that they cause in patients who don't die, 116 million years of healthy years of life lost. And that means a country of people bigger than Vietnam that every year are disabled for many, many years. And this burden has been neglected by us as a global community for a very long time. And the saddest part of it all, in my view, is that it is shouldered, the burden is shouldered by low and middle income countries. I originally come from India, and which is a low and middle income country, and much of Asia is low and middle income. And low and middle income countries have 75% of all stroke deaths and 81% of total daily adjusted life years. And this certainly is part of the reason why stroke is neglected, because it is affecting countries that have very low resources to fight this. However, the global community does take notice when there is a real pandemic, right? The COVID pandemic recently caused 6 million deaths over 2 years, so double almost of what stroke causes every year, I should say that COVID caused half of stroke deaths in a year, and yet the attention paid to this real pandemic was, a million times more, and it was stopped, so to speak. We overcame it as a global community, and certainly, while these are two very different types of diseases, the attention that the global community pays to a disease and fighting it makes a big difference. And so it is certainly, in my view, a neglected problem, and the neglect leads to a very heavy economic loss that is not well known. we calculated what is called the value of lost welfare, which is a comprehensive measure of a financial burden on a global level with a very talented group of neurologists and neurosurgeons at Harvard, and we found that every year stroke causes a global economic burden of $2 trillion. Just think about it. It's 1.6% of the global GDP. It's not a small burden whatsoever. And this, of course, is because not only because of the death and the disability, but a number of people suffering from stroke in the low and middle income countries, which are contributing to 80% or more of the morbidity, have a productive life that is cut short. So their productivity is gone. Stroke occurs in the fifth decade, in the late 50s to early 60s in low and middle income countries on an average, and that's a very productive person that is lost, that loses their productivity. And so this burden, it needs to be tackled on a global level as a global community, and to do that, SVIN, the Society for Vascular and Interventional Neurology, launched Mission Thrombectomy, which was initially called Mission Thrombectomy 2020 in 2016. And I'd like to share with you the campaign, the mission itself, and all that has been achieved, and our ongoing work to tackle the burden of stroke, disability, and death. What is the basis of Mission Thrombectomy? The basis is very simple. In 2015, there were 6 landmark trials, I'm only showing 5, that established thrombectomy as a very powerful therapy with remarkable benefit. You can see here the clear, significant benefit of thrombectomy as compared to medical therapy that all of you are familiar with. And this benefit is extraordinary. It's exceptional for a medical treatment. Only a number needed to treat of 2.6. This is close to antibiotics that have a very low number to treat, to have one person independent. And so if you compare IV thrombolysis to thrombectomy, you can see that thrombectomy leads to many more patients being independent, which is shown here in green. And so this highly effective therapy is a weapon or a real tool in our global toolbox to overcome the morbidity and mortality from stroke, because large vessel occlusions, which cause the which are causing about 30% of all stroke, contribute to about 65% of the burden of morbidity, of disability, and majority of the proportion of mortality. And if we are able to treat these, then we can really fight the big burden that stroke causes. But more importantly, studies both in high-income countries and low-income countries of health economics have shown that the treatment is highly cost-effective. Do I have until 10:40? Because I have the light going on here. Okay, I don't want to. Okay, so this study here from Saudi Arabia looked at a simulation health economic analysis to quantify the impact of developing stroke care in the country, and they showed that if you gradually increase the uptake of more effective treatments like thrombolysis and thrombectomy, it leads to a cost saving of over $600 million over 15 years, despite the upfront investment. And so you can see here that even though the initial investment is very high and the cost savings are not more, the cost savings really go up with time, because you're saving a lot of people from getting disabled and dying. And this has now been shown in analysis of the landmark trials, as well as the resilience study that was done in Brazil, that the treatment is highly cost effective. And what I would say is that these two factors, the thrombectomy being highly beneficial to patients and being highly cost effective, is the reason that it needs to be addressed by the global community and made universally accessible. And that is the basis of why Mission Thrombectomy was founded. The other reason that Mission Thrombectomy is necessary, we think, is that access to thrombectomy is quite challenging. Of course, it's a emergency. Acute stroke is an emergency. It's unpredictable when it's going to happen. It can happen at any time. And it's very poorly recognized because it's not painful. And the outcome is highly time sensitive. These three challenges are not only affecting low and middle income countries, but even in the US, 1 in 3 patients with stroke symptoms call their family doctor first instead of calling 911. And the distribution of stroke centers, even in the US, is not enough, because for thrombectomy, it was estimated that there is a need for additional 20 optimally placed centers in the US per state to get a 63% of the US population within 15 minutes to a comprehensive stroke center for a thrombectomy, which is the ideal, the very ideal time that a patient should be able to access thrombectomy, so that the time-sensitive outcome is good for them. And so this triple challenge really makes access to thrombectomy quite hard in both high-income countries and low-income countries, and the gap was quite massive. So it's estimated that 10% of strokes, if we take 10% of all strokes as a conservative measure of being large vessel occlusions, but there are about over 1 million LVOs per year. This is probably an underestimate, but let's just take it as 1 million LVOs per year. In 2016, less than 100,000 thrombectomies were performed globally, and that has increased to about 300,000 as of 2025. And 12 years or 11 years since proving thrombectomy, we still have a close to 70% gap in patients who are not getting thrombectomy. And that's quite a problem. But this is not unexpected. My friend Dr. Arun Sharma from the University of Miami Business School really educated me on how new treatments are accessed. And in 1964, E.M. Rogers wrote this monograph about how new innovations diffuse, including medical treatments. And he showed that it can take up to 3 to 4 decades for a new technology, including medical treatments, to be widely available. And this is well known with PCI for STEMI in low and middle income countries. It's taken 3 to 4 decades. And what we don't want is that this very slow increase in access for 3 to 4 decades needs to be shifted to the left, and we want at least 50% of the world to have 50% access, or all, I should say, all the countries to have at least 50% access within these 2 decades, so that patients get the highly effective therapy and are saved from disability and death. So Mission Thrombectomy was launched in 2016 by SVIN. I had the privilege of founding the campaign, And as of I also was the global chair until 2 years ago, and now I'm the global chair emeritus. But we have, along with the global chair, the current global chair, Dr. Fawaz Al-Mufti, 18 other interventional and stroke neurologists in the US who form the core executive committee. This is the organization that function as a hub for the global mission. This hub coordinates with regional committees, including in Vietnam and 90 other countries, to work on increasing access to thrombectomy. Each regional committee in each country has a co-chair for thrombectomy, a co-chair for stroke, and we have recently started to include a co-chair for emergency medicine, and committee members that all work together with the core executive committee to increase access to thrombectomy in their local regions. The vision and the mission is that Mission Thrombectomy is a global coalition, a horizontal peer network initiated by SVI and that aims to accelerate worldwide access to rapid emergency mechanical thrombectomy. And we want to do this by integrating the disparate knowledge of barriers that is present in every country, unify multiple efforts by local and specialty societies, and we aim to do this by developing and implementing high-impact public health interventions. When we started, we aimed to double the access every 2 years for the next decade, and I'll show you that we did achieve the 202,000 thrombectomy goal in 2020, 6 years ago. The regional committees have an action plan. They just disseminate the white paper to the policymakers in their individual countries that has been written by Mission Thrombectomy that tells them what is a stroke, what is LVO stroke, how to develop thrombectomy systems of care. And we also developed a smartphone app that is undergoing a revision right now to track thrombectomies. We conduct regional surveys and analysis of the infrastructure, and we coordinate with the regional committees to develop every year public health interventions to increase access to thrombectomy. And one of the ongoing public health interventions is stroke center certification in their countries. What are public health interventions? Public health interventions are upstream strategies that are not hospital by hospital. They are on a country and state level where they target economic, political, and community factors that could substantially increase access to treatment. And this means policies and investment at the governmental level. What kind of targets do these public health interventions have? We wrote this paper about the well-known concept of pillars of access. The first pillar of access is information and diagnostic access. Public awareness about stroke and education of doctors on LVO stroke and its triage is the first access that needs to be developed. I'm going to go a little fast. Physical barriers, which include the thrombectomy centers and thrombectomy specialists, are the second targets of these public health interventions. And then the financial pillar is a crucial target because reimbursement of thrombectomy and investment into a thrombectomy systems of care are extremely important. So how do we put all these together? We advocate with policymakers and other stakeholders. We do population education to increase awareness among both the non-medical and medical personnel about LVO and LVO stroke and thrombectomy. And then we leverage technology, including what I spoke about yesterday, which is really cutting-edge technologies that are emerging, like remote thrombectomy. But until then, using a lot of the smartphone and tele-observership to increase access to thrombectomy. Our growth has been really quite extraordinary. We were launched in 2016. We did a pilot survey in 2017 in the US. We did a formation of the global executive committee and the regional committee starting in 2019. And as of 2025, we have 109 regional committees in over 90 countries. This has really been quite amazing to achieve, and this has allowed us to be in all 6 continents, and we are now able to do registry and research. We have collaboration with WSO, which is the World Stroke Organization, American Heart, with Angels, with multiple companies. We do education and training. I told you about the work with the regional committees of advocacy, education, and increasing access with technology. We raise funds to achieve our mission through grants and other means, and we collaborate with the World Health Organization and the UN to advocate for stroke access globally. We did the first study called Empty Glass to show to quantitate the global access to thrombectomy. We had 887 survey responses from 61 countries, and we found that global access to mechanical thrombectomy is staggeringly low at 2.79% only. It's less than 1% for 18 countries in the survey, and there is a 460-fold disparity between the highest country and the lowest country, which is Australia has 46% access in this study, and Bangladesh has 0.1% access to thrombectomy after excluding all the countries that have zero access. And this kind of disparity would be never acceptable in a global disease in general, like the pandemic, but it is the reality for stroke. What you can also see is that the access is totally correlated with the GDP of the country. Low and middle income countries have less than 0.5% access. Middle income countries have 2.7% access, and high income countries on a median have 21% access to thrombectomy. So this is where we need to work on. This is the white paper that we wrote in 2020 and disseminated across now 25 countries and translated into over 19 languages. We have our website that's very educational and both for the public and the doctors. And we, as I said, have multiple country health ministries endorse the white paper and adopt it. This is a release in India in 2022 that led to in 2021 that led to a tripling of reimbursement for thrombectomy in the Ayushman Bharat insurance scheme for low-income citizens in India, and the access to thrombectomy has certainly improved since then. And as I said, the white paper has been translated into 19 languages and adopted in multiple countries. Mission Thrombectomy is a consultant society for the UN ECOSOC, and we advocate for thrombectomy, and we work with multiple organizations, including the WSO, to advocate for increasing the visibility of thrombectomy in the WHO policies. WHO has listed thrombectomy devices as essential devices. This is the app that we use to track thrombectomy. It's undergoing a revision, and the countries that have really taken this to a next level include China, where the China Mission Thrombectomy Committee has doubled the thrombectomy between 2020 and 2022 and has shown how this approach really works. We have multiple countries that we are working with. This is a Sierra Leone plan, so even small countries in sub-Saharan Africa that we are working with to increase access. We do multiple workshops. This is Dr. Nijasri in Thailand, who worked with us for workshops there. This is a workshop in India that I conducted along with others last year, and this is something that, 2 years ago, that helps local thrombectomy teams to increase their experience with thrombectomy and implement thrombectomy systems. We've also launched the Silk certification. That is a certification for angiography suites to certify angiography suites for thrombectomy and meet the highest standards. And this is something that's now been done in over 20 angiography suites around the world, and we're hoping to do it in Ho Chi Minh City also at the People's 115 Hospital soon. There's a formal application system that's online, and it's actually free of charge, and it allows for the highest level of thrombectomy performance by an angiography suite. We were invited by the UN General Assembly and Global Stroke Coalition to a side event at the UN General Assembly last week. This is Dr. Fawaz Al-Mufti and me to talk about mission thrombectomy. And we've co-authored the Lancet Neurology Commission with WSO on stroke and stroke access, and we have multiple partners across industry and societies to achieve our mission. We launched the World Thrombectomy Day in 2021 as May 15th, and this has been now observed for the last 5 years around the world. And we do many public health campaigns that are around World Thrombectomy Day. And we have launched a teleobservership as of last year that allows for early career thrombectomy specialists to log in from their home on their smartphones and watch thrombectomy and other neurointerventional procedures live with a two-way exchange. And the grassroots trial is something that I had the privilege of leading. It's not through Mission Thrombectomy, but it was really inspired by Mission Thrombectomy to conduct a new device trial in India for thrombectomy that has been now approved in India. This is a Be Fast challenge that we did around World Thrombectomy Day to use dance as a method of communicating the signs and symptoms of stroke to the public. I'm not going to play the whole video, but we used dance and we challenged people to put this on social media. So this is loss of balance that she's showing with Bharatanatyam from India, and this is the eyes. She's showing that the sudden eye symptoms can be a stroke symptom, sudden face droop, and sudden loss of arm strength, and then the loss of speech, and then time to call 911. And this sort of public challenge is what is needed. We were featured in the New York Times 2 years ago and in multiple other publications. So in conclusion, even after 11 years of proving thrombectomy being highly effective for large vessel occlusion, the global access to thrombectomy remains below 5%. According to the empty glass study, this access is highly disparate, and almost a 500-fold disparity exists in the globe for access to thrombectomy. The three well-established barriers to treatment access, information access, physical access, and financial access, can really guide solutions to overcoming barriers to access. Global health initiatives such as Mission Thrombectomy, the World Stroke Organization Implementation Task Force, and the GSAC can aim to address these inequities and gaps in access to thrombectomy. Public health interventions customized to the country and region are highly powerful, well-proven tools to implement continuous growth in access to thrombectomy with local stakeholders, and multi-stakeholder collaboration along with policymakers, politicians, with hospital CEOs, and communication with these stakeholders can develop and build empty system strokes of care and accelerate access to thrombectomy. I want to acknowledge all the core executive committee members, as well as all the global executive committee members around the world, including Vietnam, for the tremendous partnership and work that they have done together. And thank you so much for listening.